Welcome to our lecture on oral pathology and surgery. Today, we'll explore various facets of oral health, from soft tissue lesions to surgical interventions. We'll start with soft tissue lesions, moving on to developmental conditions and osteodystrophies affecting the jaws. Then, we'll dive into tumors of the jaw and oral manifestations of systemic disease. Shifting gears, we'll discuss oral surgery, covering exodontia, extraction techniques, apical surgery, and cysts interfering with eruption. We'll also explore autotransplantation of teeth and implantology. Finally, we'll touch on soft tissue, including frenectomy and mucocoele management. Join us as we unravel the complexities of oral health and surgical interventions. Let's begin our journey into oral pathology and surgery, lesions of the oral soft tissues. Classification. Infections. Ulcers. Vesiculobolus lesions. White lesions. Cysts. Tumors. Infections. Viral infections. Herpetic infections. Primary herpes simplex infection. Occurs in children aged 6 months to 5 years. Symptoms and treatment covered in Chapter 11. Secondary herpes simplex infection. Occurs at the labial mucocoele junction. Presence as a vesicular lesion. Herpes varicella zoster. Shingles, more common in adults. Vesicular lesion in trigeminal nerve distribution. Chickenpox. Vesicular rash on skin. Intraoral lesions resemble primary herpetic infection. Other viral infections. Mumps. Painful enlargement of parotid glands, usually bilateral. Measles. Oral manifestation on buccal mucosa as complex spots, precedes skin lesions. Rubella. Usually no oral signs, tonsils affected. Herpangina. Coxsackie virus A infection, vesicles in tonsillar or pharyngeal region. Hand, foot, and mouth disease. Coxsackie virus A infection, maculopapular rash on hands and feet. Infectious mononucleosis. Bar virus, oral ulceration, petechial hemorrhage, lymph node enlargement. Human papillomavirus. Associated with various tumor-like lesions of the oral mucosa, bacterial infections. Staphylococcal infections. Impetigo. Affects angles of the mouth and lips. Presence as crusting vesiculobolus lesions. Vesicles coalesce to produce ulceration. Self-limiting, antibiotics may be prescribed. Can cause osteomyelitis of the jaws in children, requiring surgical intervention. Streptococcal infection. Varies from mucopurulent nasal discharge to tonsillitis, pharyngitis, and gingivitis in childhood. Scarlet fever. Skin rash with maculopapular lesions of mucosa. Associated with tonsillitis and pharyngitis, tongue changes from strawberry to raspberry-like appearance. Congenital syphilis. Transmitted from infected mother to fetus. Oral mucosal changes include regades, scarring at angle of mouth. Characteristic dental changes in dentition, Hutchinson's incisors, mulberry molars. Tuberculosis. Rare oral cavity lesions, more commonly affects submandibular and cervical lymph nodes. Tuberculous lymphadenitis presents as tender enlarged nodes, may progress to abscess formation. Surgical removal of affected glands recommended for neater scar. Cat scratch disease, self-limiting disease causing enlargement of regional lymph nodes. Nodes are painful and may suppurate following a cat scratch. Treatment involves incision and drainage. Fungal infections. Candida. Neonatal acute candidiasis, thrush. Commonly contracted during birth. Young children susceptible, especially after antibiotic therapy. White patches on erythematous or bleeding base. Treatment with nystatin or myzole. Dosage. Under 2 years, 2.5 milliliters of miconazole gel, 24 milligrams per milliliter, twice daily. Under 6 years, 5 milliliters twice daily. Over 6 years, 5 milliliters 4 times daily. Actinomycosis. Can occur in children, often following intraoral trauma or dental extractions. Organisms spread through tissues, causing dysphagia if submandibular region involved. Abscesses may rupture onto skin, requires long-term antibiotic therapy. Penicillin prescribed for at least 2 weeks following cure. Protozoal infections. Toxoplasma gondii. Occasional infection in children, with cats as principal reservoir. Glandular toxoplasmosis similar to infectious mononucleosis, mainly in children and young adults. Granulomatous reaction in oral mucosa, parotid gland enlargement. Self-limiting, may require antiprotozoal treatment like pyrimethamine in severe cases. Ulcers. Traumatic ulceration. Occurs on tongue, lips, and cheek, especially after local anesthesia. Recurrent aphthous oral ulceration. Not associated with systemic disease. Common in children. Characteristics. One or more small and non-attached gingiva. Symptoms may be mistaken for toothache. Majority are minor, less than 5 mm in diameter, healing within 10 to 14 days. Treatment. Often reassurance is sufficient. Topical steroids may be prescribed in severe cases. Children may benefit from antiseptic rinses to prevent secondary infection. Any ulcer lasting longer than 2 weeks without history of major aphthous ulceration should be biopsied. Vesiculobolus lesions. Characteristics. Cause ulcers in later stages. Viral causes mentioned earlier. Other conditions. Epidermolysis bullosa. Erythema multiforme. Epidermolysis bullosa. Encompasses various symptoms, some incompatible with life. Extremely fragile skin, mucosal involvement possible. Suckling may induce bully formation in babies. Effective oral hygiene challenging in older children due to painful lesions. Erythema multiforme. Oral lesions mainly affect lip and anterior oral mucosa. Initial erythema followed by bully formation and ulceration. Pathogenesis unclear, precipitating factors include drug therapy and infection. Treatment. Involves steroids and oral antiseptic/analgesic rinses to ease pain. White lesions. Trauma. Chemical or physical trauma, e.g., burns, occlusal trauma, can cause intraoral white patches. White spongy nevus. Also known as oral epithelial nevus. Rough folded lesion affecting any part of oral mucosa. Often in infancy, benign. Leukoedema. Folded white translucent appearance. Found in children of races with oral mucosal pigmentation. Considered a variation of normal. Candidiasis. Acute fungal candidiasis, white patches readily removed. Tongue. Symptoms. Normally symptomless, some discomfort with spicy foods. Appearance. Shiny, red patches due to loss of filiform papillae. Surrounded by white margins. Characteristics. Patches disappear and reappear in different tongue. Benign, requires no treatment except reassurance to child and parent. Cysts. Mucocoeles. Peak incidence in second decade of life, not uncommon in younger children. Caused by trauma to minor salivary glands or ducts, often located on lower lip. Most common non-infective cause of salivary gland swelling in children. Ranula. Bluish swelling of floor of mouth, essentially a large mucocoele. May arise from sublingual salivary gland. Bons nodules. Gingival cysts from remnants of dental lamina. Found in neonates, usually disappear spontaneously. Epstein's pearls. Small lesions along palatal midline, arise from trapped epithelium in palatal raphe. Present in about 80% of neonates, disappear within a few weeks. Dermoid cysts. Rare lesions of floor of mouth, appearing as intraoral and submental swellings. Derived from epithelial remnants at fusion of mandibular processes. Lymphoepithelial cyst. Historically termed branchial arch cyst. Found in sternomastoid region, may present in floor of mouth. Cyst wall, contains lymph tissue, thought to originate from salivary epithelium. Thyroglossal cyst. Arises from thyroglossal duct epithelium. Rarely presents intraorally, mostly in region of hyoid bone. Tumors. Congenital epulis. Rare lesion in neonates, usually in anterior maxilla. Consists of granular cells covered by epithelium, benign. Melanotic neuroectodermal tumor. Rare tumor in early months of life, usually in maxilla. Epithelials containing melanin with fibrous stroma. Benign, simple excision curative. Squamous cell papilloma. Benign condition in children, caused by human papillomavirus. Small pedunculated cauliflower-like growths, varying in color. Verruca vulgaris. Common, may present as solitary or multiple intraoral lesions, associated with human papillomavirus. Focal epithelial hyperplasia, Hex disease. Rare condition associated with human papillomavirus. Multiple small elevations of oral mucosa, especially in lower lip. Fibroepithelial polyp. Fairly common lesion as firm pink lump. Affects buccal mucosa at occlusal level, caused by trauma. Usually symptomless, easily removed. Fibrous epulis. Mass on gingiva, varying in color, pink to red. Consists inflammatory cell infiltrate and mature fibrous tissue, benign. Surgical excision curative. Pyogenic granuloma. Commonly on gingiva, usually in anterior maxilla. Probably reaction to chronic trauma, tendency to recur after removal. Peripheral giant cell granuloma. Dark red swelling of gingiva, occurring in children. Often arises interdentally, may show loss of interdental crest on radiographs. Hemangiomas. Relatively common in children, malformations of blood vessels. Divided into cavernous and capillary variants, may present as facial birthmarks. Cavernous hemangiomas hazardous during surgery, require preoperative evaluation. Sturge, Weber syndrome. Hemangioma of leptomeninges with facial hemangioma. Can cause mental deficiency, hemiplegia, ocular defects. Lymphangiomas. Benign tumors of lymphatics, mostly found in children. Common in head and neck region, cystic hygroma variant may extend intra. Neurofibromas. Solitary or multiple lesions, considered hamartomas. Present as mucosal swellings on tongue or gingivae, multiple oral neuromas in multiple endocrine neoplasia syndrome. Orofacial granulomatosis, OFG. Clinical appearance involving diffuse swelling lips and cheeks, gingivitis, oral ulceration. May represent localized allergic reaction or underlying systemic condition. Melkerson-Rosenthal syndrome. Begins during childhood, consists of chronic facial swelling, usually lips, facial nerve paralysis, fissured tongue, malignant tumors of the oral soft tissues. Epithelial tumors. Rare in children, examples include squamous cell carcinoma. Malignant salivary neoplasms uncommon, mucoepidermoid carcinomas reported in young patients. Lymphomas. Hodgkin's and non-Hodgkin lymphomas relatively rare in pediatric age group. Exception, Burkitt's lymphoma endemic in parts of Africa, affecting those under 14 years. Accounts for almost half of all malignancies in children in affected areas. Multifocal, with jaw tumor, often in maxilla, as presenting symptom. Linked to Epstein-Barr virus. Rhabdomyosarcomas. Malignant tumors of skeletal muscle. Present around 9 to 12 years of age, usually in tongue. Metastases common, poor prognosis. Cysts. Eruption cysts. Dentigerous cysts, presenting as swellings of alveolar mucosa. May precede eruption of primary and permanent teeth. Dentigerous cysts. Most common jaw cyst in children. Originates from reduced enamel epithelium, prevents eruption of affected tooth. Radicular cysts. Related to apex of non-vital tooth, rare in primary dentition. Often symptomless, discovered radiographically. Treatment, extraction, apicectomy, or conventional endodontics. Keratinizing odontogenic tumor. Formerly known as odontogenic keratocyst, aggressive. High recurrence rates due to regrowth from remaining fragments after subtotal removal. Associated with Gorlin-Gold syndrome, especially in children. Non-odontogenic cysts. Nasopalatine duct cyst, swelling in anterior midline palate. Radiographic appearance, radiolucency greater than 6 mm in diameter in position of nasopalatine duct. Surgical excision curative. Globulomaxillary cyst, odontogenic origin, either radicular cyst or keratinizing odontogenic tumor. Hemorrhagic cyst, found in children and adolescents, commonly in mandible. Often asymptomatic, appears as scalloped radiolucency between roots of teeth. May regress spontaneously or after surgical intervention. Developmental conditions. Minor problems. Examples include tongue tie. Readily treated under local anesthesia. Severe craniofacial disorders. Examples include Crouzon syndrome. Require a combined interdisciplinary approach involving maxillofacial surgery and neurosurgery. Osteodystrophies. Fibrous dysplasia. Variants, monostotic, polyostotic, or part of Albright's syndrome. Monostotic type most common in jaws, especially maxilla. Presents a slow-growing bony expansion, causing facial asymmetry and malalignment of teeth. Radiographically, fine granular radiopacity. Surgery can correct asymmetry. Cherubism. Rare condition characterized by fullness of cheeks and jaws. Typically presents between 2 and 4 years of age, size increases during growth. Self-limiting, regression occurs in adulthood. Multilocular radiographic radiolucencies at angles of mandible and maxillary tuberosities. Histologically similar to giant cell granuloma. Cosmetic surgery may be considered after active growth has finished. Tumors of the jaws. Odontomes. Hamartomas containing dental calcified tissue. Classified as compound, anterior maxilla, or complex, premolar/molar regions. Usually symptomless, diagnosed radiographically. Surgical excision required if interfering with tooth eruption, or part of orthodontic treatment. Juvenile ossifying fibroma. Benign lesion with rapid growth. Consists of fibrous tissue with varying mineralized material. Usually affects mandible, radiographically shows well-circumscribed radiolucency with speckling. Surgical excision necessary. Central giant cell granuloma. Bone swelling usually affecting mandible. Radiographically presents as well-defined radiolucency with occasional tooth resorption. Histologically characterized by large numbers of osteoclast-like cells in vascular stroma. Surgical curettage curative. Histiocytoses. Langerhans cell histiocytosis, formerly histiocytosis X, predominantly affects children. Can be solitary or multifocal lesions. Bone replaced by Langerhans cells, producing sharply defined radiographic radiolucencies. Ameloblastoma. Locally invasive neoplasm, usually in mandible. Slow-growing, often symptomless in early stages. Surgical resection to sound bone necessary for cure. Ameloblastic fibroma. Rare benign tumor, affecting younger age group. Average age at diagnosis, 14. Related to ameloblastic fibrodontoma, containing dentine and enamel. Primary interosseous carcinoma. Very rare tumor, usually in children. Arises from odontogenic epithelium, showing rapid growth. Sarcomas. Rare, Ewing sarcoma, malignant. Occurs in children aged 5 to 15, usually affecting mandible. Prognosis poor. Crohn's disease. May present with specific pathological conditions in the mouth. Chronic renal failure and diabetes. Predisposed to periodontal disease. Poor resistance to odontogenic infection spread. Other systemic conditions. Temporomandibular joint involvement in juvenile rheumatoid arthritis. Jaws affected in hyperparathyroidism, giant cell tumors. Role of dental practitioners. Oral condition may be the presenting feature of systemic disease. Dentists should refer children with abnormal oral signs for further investigation. Exodontia in children. Differences between primary and permanent teeth. Size. Primary teeth are smaller in every dimension. Roots of primary teeth are smaller but proportionately greater. Shape. Crowns of primary teeth are more bulbous. Roots of premolars are more splayed and furcation is positioned more cervically. Physiology. Roots of primary teeth resorb naturally, unlike permanent teeth. Support. Bone of the alveolus is more elastic in children. Modifications to extraction techniques. Types of forceps for primary and permanent teeth. Forceps for primary teeth have smaller beaks and handles, with more curved beaks to accommodate bulbous crowns. More expansion of the socket is required for primary teeth due to wide splaying of roots, problems peculiar to child patients. Natal and neonatal teeth. Most found in the mandible, and may be supernumeraries. Infraocclusion. Surgical division may be necessary for removal. Fusion/gemination. Elevators used, sometimes with tooth division and bone removal. Damage to permanent successor. Caution needed to avoid damage during extraction. Dislocation of mandible. Easily occurs during extractions under general anesthesia, due to less pronounced articular eminence in children. Support must be provided to prevent dislocation before the patient regains consciousness. Extraction techniques in children. Patient position. Local anesthesia. Child seated in a dental chair, reclined at about 30 degrees. Operator stands in front of the patient for upper teeth, mouth level below operator's shoulder. For lower teeth, operator stands in front or behind depending on side, with patient's mouth at appropriate height. General anesthesia. Patient usually supine. Mouth at a level, just below the operator's elbow. For lower right teeth, operator stands behind, for others, in front of the patient. Non-working hand. Rolls. Retracts soft tissues for visibility and access. Protects tissues if instrument slips. Provides resistance to extraction force on mandible to prevent dislocation. Provides tactile feedback to the operator. Order of extraction. Symptomatic teeth first, balancing extractions on opposite side. Lower teeth extracted before upper teeth to eliminate bleeding interference. If symptomatic teeth in all quadrants. Right-handed operators start with lower right extractions to minimize position changes and reduce anesthesia time. Extraction techniques for upper primary and permanent anteriors. Preparation. Luxator and straight elevators. Luxator inserted buccally and lingually to loosen tooth attachment. Straight elevators like Coupland design used for further loosening and initial movement. Normal position. Maxillary anteriors. Apply forceps beaks to root, then rotate clockwise and anti-clockwise around the long axis. Upper canine. May require additional buccal expansion for removal in older children. Malpositioned teeth. Labially placed lateral inside canines. Use straight forceps or elevators, applying rotatory movement or slight rotation. Palatally positioned teeth. Use elevators applied on palatal surfaces, rotating towards the midline. Curved Warwick-James elevators. Right-sided applied mesially/distally on the right/left side, left-sided opposite, upper primary molars. Forceps application. Apply upper primary molar forceps to roots. Initial movement palatal, then continuous buccally directed force for delivery. Inadequate buccal movement due to caries. Complete extraction with continued palatal expansion. For premolars. First premolar. Removed by buccal expansion with upper premolar forceps. Second premolar. Single-rooted, attempt buccal expansion first, if unsuccessful, rotate about long axis. Palatally displaced premolars. Use elevator to palatally placed canines. Upper permanent molars. Forceps application. Apply left and right upper molar forceps to roots. Deliver by expanding socket in buccal direction. Palatal expansion may cause fracture and is less successful. Extraction techniques for lower primary and permanent anteriors. Lower primary anteriors. Extracted similarly to upper counterparts, using rotation about the long axis with lower primary anterior or root forceps. Lower permanent anteriors. Lower incisors. Not removed by rotation due to thin roots. Remove with lower root forceps, expanding the socket labially. Lower canines. Delivered by rotatory movement or buccal expansion. Labially displaced canines removed similarly to upper anteriors. Lingually placed anteriors required elevators applied mesially and distally. Lower primary molars. Extracted by buccolingual expansion of the socket with lower primary molar or root forceps. Apply forceps to the bifurcation, then use lingual movement followed by continuous buccal force for delivery. Lower premolars. Fully erupted lower premolars usually removed by rotation around the long axis with lower premolar forceps. Lingually positioned lower second premolars can be difficult, use straight elevators or upper fine root forceps. Lower permanent molars, lower molar forceps. A region of bifurcation buccally and lingually. Move tooth buccally to expand buccal cortical plate. If buccal expansion insufficient, move forceps in figure of 8 fashion to expand socket lingually as well. Cowhorn design forceps. Apply to bifurcation, squeeze handles together. Beaks approach each other, displacing tooth in occlusal direction for extraction. Both methods successful, choice depends on operator preference. Management of buried teeth. Buried teeth, including supernumeraries, are treated in children for various reasons. Symptomatic, e.g., pain. Radiographic signs of pathology, e.g., dentigerous cyst formation or resorption of another tooth. Part of an orthodontic treatment plan. If buried teeth are asymptomatic, have no associated pathology, and do not pose orthodontic problems, they should be left alone but monitored regularly for any developing issues. However, in cases where unerupted teeth need removal, the following steps are taken. Localization. Clinical examination and radiographic techniques are used. Radiographic views may include parallax periapicals, orthopantomogram, occlusal views, true lateral facial bones, or cone beam CT scanning. Cone beam CT scanning provides clear buccolingual position of the buried tooth. If standard radiography is used, views at different angles are required to localize the tooth in the buccolingual plane using parallax. Assessment. Evaluate the overall shape of the tooth, its relationship to neighboring structures, such as the antrum, inferior alveolar nerve canal, and other unerupted teeth, and the extent of any associated pathology. Determination of removal method. Assess the difficulty of removal and patient cooperation. Decide on the method of anesthesia based on patient factors and the complexity of the procedure. Extraction of buried teeth. When extracting buried teeth in children, achieving an excellent view of the operative field is crucial, especially for teeth closely associated with other unerupted teeth that are being retained. Here's how it's done. Flap design. Flaps should be mucoperiosteal. Be cut at a 90 degrees angle to the bone. Have a good blood supply. Avoid damage to important structures. Allow atraumatic reflection. Provide adequate access and visibility. Permit reposition of the wound margins over sound bone. Preoperative assessment. A preoperative examination reveals the presence of a palatal supernumerary tooth along with unerupted tooth 11. This is likely confirmed by radiographic imaging. Surgical procedure. The procedure begins with the removal of the supernumerary tooth and the erupted teeth 50, 52, 51, and 63. These teeth are likely extracted to create space for the eruption of tooth 11 and to address any crowding issues. The palatal gingival margin is incised to provide access to the underlying bone and teeth. A small palatal flap is raised to expose the underlying structures clearly. Identification of supernumerary tooth. Once the flap is raised and the bone is exposed, the supernumerary tooth is identified. It may be embedded within the bone or located adjacent to the erupted teeth. Removal of supernumerary tooth. The supernumerary tooth is carefully removed after the surrounding bone is accessed and removed as necessary. Special care is taken to avoid damaging adjacent teeth and structures. Postoperative care. After the supernumerary tooth is removed, The area is likely irrigated and cleaned to remove any debris. The small palatal flap may be reopened and sutured back into place to facilitate proper healing. Follow-up assessment. Following the procedure, the patient will require follow-up appointments to monitor healing and ensure proper eruption of tooth 11. Radiographic imaging may be performed at subsequent visits to assess the position and development of tooth 11 and the surrounding structures. This procedure aims to address the presence of a palatal supernumerary tooth and facilitate the eruption of tooth 11 in a 9-year-old child. It involves careful surgical techniques to remove the supernumerary tooth and create space for the proper alignment of the remaining teeth. Tooth removal. Once enough bone is removed to identify the tooth to be extracted and expose the greatest diameter of its crown, elevation of the tooth should commence. If elevating the tooth risks undue pressure on neighboring teeth, or if the tooth is difficult to elevate, it should be divided using a handpiece and burr, then removed in parts. Mandibular teeth impacted within the arch are best removed using the broken instrument technique. This involves applying pressure from one side of the tooth, e.g., using a straight Warwick-James elevator, to force it out from the other side. Suturing. Resorbable sutures, preferably 3/0 or 4/0 Vicryl, should be used in children whenever possible. Discharge. Any bleeding should be stopped before the patient leaves the surgery. Patients and parents should receive instructions on simple methods of hemorrhage control. Encourage good oral hygiene and may prescribe an antiseptic mouthwash. Emphasize the risk of self-inflicted trauma in anesthetized areas. Pain relief. Simple analgesics are usually sufficient. Avoid aspirin in children under 12 due to its association with Reye's syndrome. Paracetamol elixir is ideal, with dosages adjusted according to age. Review. At the review visit, examine the surgical swelling, check for evidence of self-inflicted trauma in the anesthetized area, and inquire about any residual altered sensation. Remove remaining sutures or allow them to resorb based on the patient's preference. Reinforce good oral hygiene. Post-extraction problems. Dry socket is rare in children with primary tooth extractions, but can occur in older children following permanent molar extractions, albeit less frequently than in adults. Local measures and analgesics are usually sufficient. Postoperative hemorrhage is occasional but can be impressive after multiple extractions under general anesthesia. Pressure with gauze or a handkerchief. If ineffective, use sutures with or without hemostatic gauze. Severe blood loss is very rare, but systemic causes should be excluded to ensure safe subsequent treatment. Surgical exposure of teeth. Extraction of primary predecessors. If erupted primary teeth are present, they may be extracted. Flap elevation. Raise a flap to expose the area, as described earlier. Extraction of buried teeth. Remove any buried teeth or supernumeraries. Bony impaction. Remove any bony impaction and expose the widest diameter of the crown. Orthodontic appliances may be placed at this stage to aid eruption if needed. Placement of pack. Place a periodontal dressing, e.g., Copac, around the tooth, and replace the flap around the pack. The pack can be inserted primary tooth sockets if soft tissue sacrifice is unnecessary. Alternatively, incorporate the pack onto the acrylic of an upper removable orthodontic appliance in some cases to maintain exposure during healing. Minimal soft tissue sacrifice. In cases where only removal of soft tissue is needed, such as exposing a totally placed canine, there's no need to raise a full flap. Sacrifice the overlying tissue and pack the wound. Excessive bleeding in the palate can be controlled by passing a non-resorbable suture across the palatal mucoperiosteum. Preserve keratinized gingiva. For unerupted teeth palpable high in the buccal sulcus under reflecosa, avoid exposing them by sacrificing overlying soft tissue. Raise a flap containing keratinized gingiva coronal to the impacted tooth, remove bone if necessary, and replace the flap in a more apical position to ensure a collar of attached gingiva around the tooth at eruption. Postoperative care. Remove the and any remaining non-resorbable sutures after about 10 days. Bonding orthodontic appliances to unerupted teeth. Localization of tooth. Localize the buried tooth as described earlier. Attachment of gold chain or magnet. bond a gold chain or magnet to the tooth using composite resin and a bonding agent. Gold chain. If a gold chain is used, bring it through the edges of the wound in the area of natural eruption of the tooth. Bond the free end of the chain to an erupted tooth or suture it to the mucosa during the healing period before orthodontic activation. Magnet. If a magnet is used, relocate the soft tissues in their original position and suture them. Incorporate a magnet with the opposite polarity within a removable appliance, which is then placed over the wound to apply the magnetic force. Surgical anchorage. Insufficient erupted dentition. In cases where there's insufficient erupted dentition for orthodontic anchorage, extraoral anchorage or bone screws/implants can be used. Orthodontic implants. Orthodontic implants may be placed, for example, in the midline of the palate. Orthodontic appliances can then be attached to these implants and removed at the end of treatment. Apical surgery. Indications. Apicectomy is rarely performed in children, but it may be indicated for teeth with intransigent open apices. Flap design. Use a triangular flap involving the gingival margin and vertical relief incision. Technique. The surgical technique is similar to that used in adults, but some differences exist in placing the apical seal, especially in teeth with immature open apices. Cysts interfering with eruption. Eruption cysts, incise eruption cysts, and dentigerous cysts can be marsupialized to the oral mucosal lining after removing any overlying primary predecessor. Dentigerous cysts. Some advocate more aggressive treatment involving enucleation of the cyst, with or without removal of the tooth, to ensure that epithelial remnants are not left behind. Fissural cysts. Fissural cysts, such as the nasopalatine cyst, are rare in children but should be enucleated when found. Treatment of acute orofacial infection. Source removal. The primary cause of orofacial infections is often dental. Dental treatments like extractions or endodontic therapy are essential for definitive treatment. Drainage. Drainage is crucial for managing acute infections. It can be achieved during procedures or through incision and drainage of abscesses, especially in the submandibular region. Prevention of spread. Preventing the spread of infection is vital. Surgical drainage and antibiotics are employed to prevent further complications. Restoring function. Restoring normal function is another goal of treatment. This may involve resolving any obstruction to breathing or eating caused by the infection. Analgesia. Pain management is crucial in treating acute infections. Prescribing analgesics like paracetamol elixir helps alleviate pain. Hydration. Adequate hydration is essential, especially if dysphagia restricts oral fluid intake. In severe cases, intravenous fluid replacement in a hospital setting may be necessary. Surgical emergency considerations. Submandibular swelling. Swelling in the submandibular region can obstruct the airway, leading to dyspnea. Urgent decompression is required, and admission to the hospital may be necessary. Infection near eye and nose angle. Infection in this area, typically arising from upper teeth, can spread intracranially, causing cavernous sinus thrombosis. Prompt treatment is crucial to prevent life-threatening complications. Antibiotic therapy. In severe cases, intravenous antibiotics, often penicillin-based like amoxicillin, are administered to manage acute infections. Drainage procedure. Extraoral incisions should be made along skin creases, parallel to the direction of the facial nerve. Care should be taken to avoid important structures like the mandibular branch. After incision, blunt dissection is carried out to locate and drain the infection. A drain is secured to facilitate drainage, and the area is monitored for 24 to 48 hours. Microbiology testing. Any pus collected during drainage should be sent to the microbiology laboratory for culture and sensitivity testing to guide antibiotic therapy. Autotransplantation of teeth in children. Autotransplantation, a procedure where teeth are moved from one location to another within the same individual, can be considered for repositioning of ectopic teeth, for example, relocating an unerupted upper permanent canine to its correct position. Replacement of restaurable teeth, substituting an unrestaurable tooth with a healthy tooth from elsewhere in the dentition. Procedure. Assessment. Evaluate the donor tooth and recipient site clinically and radiographically. Extraction of donor tooth. extract the donor tooth atraumatically, minimizing contact with the root surface. Preparation of recipient site, enlarge the recipient socket if needed and ensure proper alignment for transplantation. Transplantation, gently place the donor tooth into the recipient site, ensuring proper occlusion and suturing the gingival margin. Splinting, splint the transplanted tooth using orthodontic and composite resin, avoiding rigid splinting to prevent ankylosis. Root treatment, depending on the maturity of the transplanted tooth, root canal treatment may be necessary post-transplant. Follow-up, regular follow-up visits are essential to monitor the transplanted tooth's progress and address any issues that arise. Movement, orthodontic adjustments can begin 3 months post-transplantation and should be completed within 9 months. Considerations. Antibiotic prophylaxis, such as oral or intravenous amoxicillin, is often administered to decrease the risk of root resorption. Cone beam computerized tomography, CBCT, and computer-aided prototyping can aid in assessing tooth morphology and planning. Post-transplant care includes maintaining good oral hygiene, removal of sutures at 1 week, and splint removal at 2 to 3 weeks, followed by regular checkups. Autotransplantation offers a viable option for correcting dental anomalies and replacing unrestorable teeth in children, with careful planning and follow-up ensuring successful outcome. A series of steps involved in a dental procedure that includes extraction of the maxillary left central incisor and its replacement with a mandibular premolar, as part of an orthodontic treatment plan. Extraction of maxillary left central incisor. The procedure begins with the extraction of the maxillary left central incisor. Widening of maxillary left central incisor socket with chisel. After extraction, the socket of the maxillary left central incisor is widened using a chisel. This step is important to prepare the socket to receive the transplanted tooth. Transplantation of mandibular premolar to maxillary left central incisor socket. The socket of the extracted maxillary left central incisor is then used as a recipient site for the transplantation of a mandibular premolar tooth. This transplantation involves carefully placing the premolar into the widened socket and ensuring proper alignment and stability. Suturing and splinting of transplanted tooth. Once the mandibular premolar is transplanted into the maxillary left central incisor socket, it is sutured into place to promote healing and stability. Additionally, a splint may be used to further stabilize the transplanted tooth during the initial healing period. Follow-up at 3 months. At the 3-month follow-up visit, heel and occlusal views of the transplanted tooth, mandibular premolar, are taken to assess its healing and integration into the surrounding tissues. These views allow the dentist to evaluate the success of the transplantation and make any necessary adjustments or further treatment plans. This sequence of steps illustrates a complex dental procedure replacing a missing maxillary incisor with a transplanted mandibular premolar, as part of an orthodontic treatment plan. It highlights the importance of careful surgical technique, proper socket preparation, and postoperative management to ensure successful outcomes. Implantology in children. While dental implants are a common treatment for adults with missing teeth, their use in children is generally contraindicated except in rare cases where severe psychological stress warrants such intervention. There are several reasons for this cautious approach. Lack of alveolar growth accommodation. Implants do not adjust or move with the growing alveolus, leading to ankylosis. Therefore, implants should not be placed until vertical jaw growth is nearly complete, typically around 18 years of age. However, exceptions may be made for the lower intercanine region in specific cases of severe hypodontia, such as X-linked dermal dysplasia. Interference with jaw growth. Implants can potentially disrupt the natural growth of the jaws in children. Bone development differences. Young bone behaves differently from mature bone. Inserting implants into immature bone can lead to deviation from the intended axis due to bone deformation and remodeling. Additionally, alternatives such as autotransplantation of teeth may be more suitable for young patients. Given these factors, the use of dental implants in children should be approached with caution, and alternative treatment options should be considered whenever possible. Soft tissue surgery in children. Soft tissue surgeries play a crucial role in addressing various functional and orthodontic issues in children and adolescents. Here's a brief overview of some common procedures. Labial frenum, a prominent midline frenum in the maxilla may contribute to a diastema, gap between teeth. While its role in causing diastema is debatable, excision of the frenum is often requested as part of orthodontic treatment. This procedure, performed under local anesthesia, involves dissecting the midline tissue and achieving primary closure through suturing. Lingual frenum, if a prominent lingual frenum interferes with speech or hygiene, it can be excised under local anesthesia. The frenum is held with forceps, and an incision is made to release it, followed by suturing. Mucocoeles, these are common in children and adolescents and may require excision if they cause functional or emotional problems. The procedure involves making an incision to the lesion and removing it through blunt dissection. Salivary glands around the mucocoele are also removed, and any dental causes of trauma should be addressed. Incisional biopsy, this procedure involves removing part of a lesion to confirm a diagnosis. It's best performed by a specialist surgeon. Excision biopsy, small lesions of the oral mucosa are removed along with an ellipse of tissue, which is then examined histologically. Lesions causing no functional issues can be monitored. Suturing, resorbable sutures are preferred for closing soft tissue wounds in children. Knots can be buried to prevent them from being lost after surgery, especially in mobile structures like the tongue and lip. Periodontal dressing, after procedures involving attached gingiva or palate, a periodontal dressing may be applied to cover the area and aid in healing. Soft tissue surgeries in children require careful consideration of the patient's age, growth stage, and potential impact on future oral health. Close monitoring and appropriate follow-up are essential for successful outcomes. To perform the surgical removal of a prominent midline maxillary frenum, follow these steps. Preoperative assessment. Evaluate the patient's dental and medical history. Conduct a clinical examination to confirm the presence of a midline diastema and assess the frenum. Take a radiograph of the upper area to rule out other possible causes, such as a mesiodens. Patient preparation. Explain the procedure to the patient, including potential risks and benefits. Obtain informed consent. Administer local anesthesia to the surgical site. Surgical technique. Incisions parallel to the frenum from the labial mucosa, beyond the prominent fibrous tissue, to the palatal mucosa. Ensure that the incision in the attached gingiva is mucoperiosteal. Dissect the midline tissue carefully, separating it from the underlying bone and interdental space. Use a curette or getter to remove any residual fibrous attachments on the exposed bone surface in the interdental space. Closure and postoperative care. Close the labial part of the incision using sutures for primary closure. Cover the defect in the attached gingiva with a pack, such as Copac, secured in place with sutures. Instruct the patient on postoperative care, including oral hygiene practices and dietary restrictions. Schedule a follow-up appointment to remove the pack and assess healing, typically 7 to 10 days after surgery. Monitoring and follow-up. Monitor the patient for any signs of infection or complications during the healing process. Evaluate the outcome of the procedure, including the closure of the diastema and any aesthetic improvements. Provide any necessary further orthodontic treatment as part of the overall treatment plan. By following these steps, you can safely and effectively perform the surgical removal of a midline maxillary frenum as part of an orthodontic treatment plan. Patient for upper midline labial frenectomy. Incisions. Parallel to the frenum and defect at the end of removal, wound closure with resorbable sutures in reflected mucosa and silk suture holding pack. Interdentally.